Welcome to the Medical Report Podcast, where we bring health to your ears. Our podcast hopes to help the community learn more about health, but we do have a disclaimer that all medical advice shared here is not an adequate means to diagnose or treat you. We recommend that you seek medical attention from your healthcare provider if you want more guidance on your health. Or if you'd like an assessment by one of us here on the panel, you can reach out through our social media pages. If anyone in the audience has any questions for us individually or about our topic today, please feel free to leave your questions in the chat and we'll answer it in our Q&A segment later in the show. If you're watching this after our live show ends, feel free to ask your questions in the comments too. Also, be sure to like and share this video. We want to feel the love. Now, let's get on with the show. Hello.
Hey.
Welcome to the Medical Report, where we bring health to your ears. We are your hosts, Nzele, Olu, and I am Anita. Today is the last episode of our first season, episode 12. And reflecting back on our first season, we have covered multiple medical topics and have had a lot of amazing guests that we've had. So we've been able to share so much knowledge about different approaches that they bring to medicine. And it's great to hear from passionate healthcare professionals in general. And to me, it feels more reassuring that the medical world continues to strive for advancements and improvements in the way that we care for our bodies. It's crazy how fast this season has gone by, right?
Yeah. It's over.
Oh. It's like it started what, June? Now we're like episode 12. It's crazy.
Yeah.
Are we really? Really? We're not.
Right.
We're not gonna cry. We're not gonna cry today. Okay, so today, basically what we're going to be doing is sharing with you guys some little pearls of wisdom, or maybe just even some updates on some topics we've even covered in the past. So today, I wanted to share more of an update on COVID. So an update that I'm sure a lot of people are aware of is that recently vaccine mandates have changed, or recommendations, should I say. So it's approved now for children aged 5 to 11 to get COVID vaccines. And CDC has also approved the booster vaccine for those who are immunocompromised or have increased risk for contracting the virus. Those people like teachers, healthcare workers, restaurant workers are among those people that can go ahead and get boosters. And that means just like that third vaccine, if you had those 2-dose mRNAs, or an extra one if you had that Johnson & Johnson. Mixing of the vaccines has also been improved. So if you had the Moderna first, you can get the Pfizer. And if you get the Pfizer, you can get the Moderna. Yeah, I don't know how I feel about that either.
I'm not mixing. No.
I don't know. I'm still getting the one I got to begin with. That's all.
I'm just of the mind, stick with the one you got. I'm not saying it's safe or unsafe. It's just my personal opinion.
I would hope that they've done some studies on this, but all of this is still very new, relatively.
Yeah.
Think about it.
I don't like anything
just came
new.
out
They have, but I'm going to stick with my Moderna.
Yeah. I have the Pfizer. I'm sticking with the Pfizer.
Well, if you remember, a long time ago, we were talking about this, and I said, "Oh no! I'm not gonna get my COVID shot for sure because this stuff is crazy." Well, I will go get my COVID shot coming up soon.
Okay.
Yes, I have. I will go get my COVID shot. Okay. It's just I said, I needed time for it to be out there and people to have taken it and to make sure that people didn't grow a third arm. And I was okay.
I don't have any third arms. I'm still living, breathing, doing fine, which is all good.
Right?
It looks like he might have a third arm, though. I don't know.
No, some people just need that extra set of security.
Back here too.
That's all it was. But so we are all gonna go get our COVID shots.
That's good. But the CDC does recommend, though, if you got that J&J vaccine, your booster needs to be an mRNA vaccine. So basically, it's because the J&J was not very effective. I had a lot of patients come. I had a lot of patients come. Well, I mean, they had those tests out before. So it was like the J&J is only 65% effective versus the mRNA vaccines that are like 93 and up. So it's
So,
like, which one do you really want to get? The one that
What
works
are
for
the
you?
mRNAs?
sorry to interrupt. So I saw actually a report that said that the J&J should have been a two-shot one to begin with. Um,
Oh. I
so
mean, I think it should have been, given that it wasn't
yeah,
super effective. But I think what drew people to it was that it was only one shot.
it was
And
one
they were like,
shot.
I just did it one and done, you know. And those are, I guess, they work best for people that may not like to get shots in general. So I guess something's
Mhm.
better than nothing.
And then
Um,
if you're out in maybe like a rural county and
yeah.
maybe it's hard to get to the local pharmacist or
Or
doctor
low
to
income,
get
and
you.
it's hard to
Yeah.
find. Yeah. Uh-huh.
Yeah. But it seemed like even when the J&J came out and people realized the efficacy rate, it was like some people just didn't even want to get it at all, even
Yeah.
though it was the only thing that was available to them. Um,
Right.
But I
but
mean, 67 versus 95. I mean,
yeah,
give me the
that's a
95.
significant difference.
Yeah.
It really, really is.
So as of right now, which one is kind of being proven as like most effective?
So right now, the Pfizer supposedly is the most effective, but they say the Moderna lasts longer, is what I've heard. So look, I was like, yeah, I got the right one. But I think
Moderna.
that came out because like Moderna actually, well, no, Pfizer was the one that came out first that said that you can get a booster with it, or that boosters will be expected, you know. And now people are testing people for antibodies, and there's nothing happening. People are not having that immunity anymore 7 months after getting both of those vaccines. So people have to be aware that they may need that booster, and be aware that if you're not eligible to get the booster, you really need to be taking precautions,
What do you
because
mean not eligible?
there are some people that can't get it right now because the booster right now I think is only able to be given to, like, you know how when the vaccine first came out, how they were like, if you're 65 and older you can have it. It's kind of like the same thing all over again, where
Oh,
they're
with the
saying,
booster.
right,
Yeah.
with the booster in particular.
Okay.
So you can get the two, like if you've never had the vaccine before, you can get the vaccine. But it's the booster in particular that they're like, we'll give you a booster if you meet qualifications, which
Oh,
is
so
the
I still
high.
need to wait a little longer. Okay.
What? Hold up. Why are we
That's all that
waiting?
told me. Is they still haven't they're still not done figuring this out.
No, they figured it out. They're just saying if you need a
They're just,
booster, that
yeah,
you have
basically,
to either be elderly or somebody who's like at risk. But if you've
Right.
never
So
been vaccinated,
here's what
go
I'm
ahead and
hearing.
get vaccinated.
Correct me if I'm wrong. I get the vaccine today.
Hmm.
6 months from now, I need the booster, but I'm not eligible. So I'm just going to be unprotected
no, you're
You,
until
eligible
I'm
because you're a
eligible.
healthcare worker.
I mean,
Oh,
six
darn.
months from
Let's
now,
just say
you
I
should be
wasn't.
eligible.
Let's
I'm
say I
just
work at
saying.
Walmart. Okay. I'm working at Walmart. So now
They
I'm no longer protected.
Man,
they
you can go
also
get
say
your
that
shot.
other people that also qualify are people that work in restaurants. So basically, if you work in a very crowded area,
Okay.
you're also eligible.
All
But
right.
if you sitting at home and you're not going nowhere, they're not about to give you no booster. That's what they say.
Our lives matter too, though.
They do. I agree. But I guess they're
Yeah, I
trying to
know what you mean,
ration it
though.
out.
They have to,
And
right. Yeah.
eventually everyone will be able to get it like it needs to be.
Okay.
But
So
yeah,
Moderna and Pfizer are
are the
pretty decent.
go-tos.
Yeah, are the go-tos. I would probably choose Moderna over Pfizer due to political reasons, but
And that's fine. That
yeah.
works.
As long as you got
Yeah.
something.
The other thing was there's also been some studies out recently about this new well, it's not a new antidepressant, it's an antidepressant that's been out there. Usually it's used for OCD. It's called Luvox.
Who?
And Luvox,
Blue box. Okay.
it's a antidepressant that they say now that people have used to decrease their, like, the length of their COVID um, symptoms. Like, so
Okay.
basically they are taking it for a 10-day course, and they're noticing that instead of it lasting them for 2 weeks or whatever, they're being recovered within like 3 days.
Okay.
Um, and it's interesting because it's a random drug to try for something like this. But they say that what it does is that it decreases the inflammatory um, markers and things in your body that
Okay.
kind of trigger when you get COVID. And so it decreases that, and because of that, it decreases the blood clots that are associated with getting with COVID. That people are, people get COVID. A lot of times, people will get blood clots, and then they get PEs, and then they pass away.
Mhm.
So these are, I think it's a really awesome finding and discovery. I'm really anxious to see how often it gets used, or if it becomes the new like go to.
Right.
But it's better than the animal medications that people are taking, I would say.
Don't take ivermectin.
No, no. People are doing that.
I had to
What?
talk a patient out of taking ivermectin. I was like, please
Yeah.
Who?
don't do this. Don't do it.
There were people taking like, what are they, like horse pills or
Yeah,
something like that?
yeah, horse dewormer. I think it's for sheep too.
They need to
But
stay off social media and quit playing.
don't do it.
People were buying them off the shelves
That's so sad.
to take them.
That's just like I remember people back in the days buying that horse mane hair wash. Okay. All right.
Oh my goodness.
People over there at the horse feed store buying hair wash for their hair so their hair
What
would
was it?
grow.
It's like Black and Lovely, or was it
Yeah,
Horse
yeah,
Mane or something?
yeah, horse mane. Okay. All right.
Don't do it, people. Don't do it. Don't fall for the hype.
Don't fall for the hype. Don't do it. Don't do it.
Yeah. So Zenzele, did you have some topic that you wanted to cover today for the people?
Well, we covered a couple of different shows, and one of the shows talked about acute care and went into facilities and how people are cared for. And one of those areas that it seems like we didn't never get a chance to kind of touch into, we touched a little bit, was into the insurance aspect and how it actually impacts your treatment, how it impacts your medical, how it pretty much drives your whole medical care. And people don't realize that your life sometimes can depend on your insurance company,
Mm-hmm.
you know? So
It's true.
I
I mean,
just
I think
wanted,
that's even like when when Obamacare came out, that was the reason, part of the reason why it was out, because there were so many people that were not able to get the care they needed because of lack of insurance.
right. Yeah. And people don't realize that just having the right insurance can get you what you need. But if you're not educated on which one to get, you could end up not having. And sometimes it's just a matter of just sharing it with people like this platform, just sharing it with people saying, hey, if you had this and this, you could get that. But if you have this, you're not going to get it. That kind of thing.
Yeah, I think at the same time there have also been some innovations and, well, innovation, some type of like, I guess, bridge toward helping those that don't have insurance. So like cash pay options are out there. I know that there's like what is that called? The sliding scale payment plans that they have now, that help patients that don't have insurance. So it's like a gradual payment plan that you end up doing. I know that that helps a lot with trying to get healthcare when they're not insured.
Mhm.
Yeah.
But again, that is still limiting because people then end up picking and choosing what they actually get done when they couldn't afford all of the tests that maybe are recommended to have done.
Yeah. And you have to kind of look at maybe your family history and your current health, because not one insurance plan, one size fits all.
Right.
So just because this insurance plan works well for this person and they're getting everything and they're getting covered and you see that your neighbor has everything, it doesn't mean that's going to be best for you. So we also have to keep that in mind. So if we make any recommendations on here and say this is good and that's good, it may be good for one person in one situation, not for all
Right.
situations. Yeah.
That's true. Oh, Lou, what's been your experience with patients and their insurances with physical therapy? Any
What
issues with getting care?
am I allowed to say? You're
What
trying to
do
affect my money here. No. Um, they can be interesting. I'll put it that way. Um,
Oh, quit trying to be nice. What's happening?
I have to be nice because they pay the bills, and and I
Mm.
love insurance companies, but sometimes they
It's-
can be a little bit in the way,
They're annoying.
very much in the way of actually giving the proper care to people. They're trying to save money, and their concern isn't so much the well-being always of the patient; it's saving money. And sometimes you have to argue back and forth, and maybe I might even have to do something that I know that I'm not going to get paid for, but it's beneficial to the patient.
Right.
Um, so
Yeah, that's true. I've definitely been there. Like it's like you want the patient to be able to get what they need, and it's hard, especially when they're there and you just want to help. I mean, that's what we're here for,
yeah.
to take care
So
of
like
our patients.
in the case of some nursing homes, no nursing home in particular, to whoever may be watching, um, an insurance may be the reason that a person gets basically kicked out because they don't want to pay anymore. Um, but that person might actually need like another week or two, and they're sending them home to go get home health or something like that. But you know,
Yeah, that's
a
true
lot of
because
Okay.
insurance
insurance
companies,
only allow a certain amount of time in the nursing home or skilled facility for them to
yeah,
rehab.
yeah.
Let me tell you
I've seen
something.
times where I've seen times where maybe as a PT, I'll put that the person can walk 100 feet. And they need this level of assistance, and the insurance company's like, "Oh, what are they doing in here? They need to go." I'm like, "Oh,
Yeah.
I said
As
they
soon as
could
they
walk
hit the
100
100
feet.
feet.
I never said it was safe. I just said that they could go 100 feet. Just
Right.
relax."
Yeah.
So you have to be very descriptive in how you do your documentation. So like, yeah, like look, they're doing good, but they're not good enough to go home. So relax.
Right. They're still not safe. That's
Yes.
really what it is. Because a lot of times patients will go home and they have like all of these like hazardous things at home, and I mean
Yep.
that's what OT goes in there and checks out their surroundings and makes sure that things are in where they should be or not be, where for safety.
I
And
think
I
for
know,
me, the most frustrating thing is that for speech, we're considered like a stepchild when it comes to therapy. So in the medical setting, so it's like Olu was saying, kick them out of here as long as they can walk 100 feet, right? Well, when it comes to speech, if they can walk, they don't need speech anymore. They can walk. They can go home. As long as you're
Yeah.
physically capable of moving, they don't care about whether you what your cognitive status is, where you are mentally. If you want to go home and you forget to turn the oven off, oh well, so be it. You could score in severe dementia, but you can walk.
right,
So hopefully, do you have a niece or sister or brother that can check in on you? If
right,
so, great, but you can still walk. So go ahead and go home. And
Yeah.
as a speech, it is the most frustrating, saddening part is the fact the insurance companies will let people go home and they're not ready to go home. And then family members will say, oh, they're ready to go home and they want them to come home so bad. And I want to tell them they're not ready to go home. Just because they can walk with their walker and they can physically do the things that they're able to do before they got in here, they had a stroke or they had this or they had that. They're not going to be able to take care of themselves anymore. They're going to need you
right,
to be around. You're
right,
going to have to do more for them,
right.
and then they get this awakening when they get in there, but the insurance company said they're good to go.
Mm-hmm. Yeah, it's true.
It's so frustrating.
Well, today we have the pleasure of having one of my favorite social workers join us today, Miss Natasha Simmons. So go ahead and bring her in. There she is.
Hi.
Hello.
Hi, Natasha.
Hi, how are you?
Good. How are you? Thanks for joining
I'm
us.
thank you. I'm doing good. I'm doing good.
So we wanted to kind of pick your brain a little bit as far as insurance is concerned. So what is the difference between Medicare Part A and Medicare Part B?
So Medicare, of course, I work in long-term care, and Medicare Part A basically covers everything, like in hospital stay, stay in the long-term, the skilled nursing facilities, therapy and things like that. And then Part B usually just covers the other services that a patient may need. So Part A covers everything. Part B comes in and covers everything else as far as medicines and appointments and things like that.
Yeah. Okay. So I know in long-term care facilities, it's frequently Medicare is usually what's used when they're
Yeah,
in like the skilled, like acute stay period, right? Like for therapy.
yes, we bill Medicare Part A for when they come in for all skilled therapy services. We use Medicare Part A, and it covers their physical therapy, occupational therapy, and speech therapy as well.
Well, it's funny because I run into situations where people want to get therapy or they need therapy, and
Mhm.
they'll have Medicare Part A and B, and they'll say, I have Medicare, but then they have an additional, like HMO Medicare. And then for some reason, it throws everything off. And they don't understand because they say, well, I have Medicare Part A and B. Why can't I get therapy?
Those are the Medicare Advantage plans. That's basically when someone, instead of having the straight Medicare, they have their Medicare kind of managed, kind of ideally like kind of like an HMO.
Right.
Um, and so most of the times they are ideal, or the patient thinks it's beneficial for them because they offer like additional services like gym memberships and things like that. But what I've noticed being in long-term care is that the managed Medicare plans, they actually kind of decide how long a person will qualify for therapy, and they kind of are usually, they don't allow the length of time that the basic or the standalone Medicare would allow.
Mhm.
So
And
is there like a major benefit to having that advantage care plan?
It really depends on the person. They, like I said, they may offer like dental coverage and coverage for a podiatrist and things like that. And those things, usually, if you're, in the elder population, those things are kind of, the to have those coverages may
Are
catch
important.
your eye, and you think, oh, okay, I need that. But then when it comes into play, if you find yourself, breaking your hip and then going to the hospital and then needing, in facility skilled care, the I don't want to really say downside, but the caution is that now it's your length of stay is going to be managed by that Advantage plan, whether it's like some are like Navi or Blue Cross Medicare, just to kind of throw a few out there. They then look at those therapy notes and those how far a patient can walk and how they're doing with occupational therapy, whether they're standby assist or, if they minimum or max assist. They look at those, and then they kind of they don't really focus on the patient. They focus on, in general, like a patient that has a hip replacement may need only, on average 20 days. And then they kind of limit it that way, but then it doesn't really take into the full picture of the particular patient at sometimes.
Right.
yeah. So I had a question. I know Med A pays for the first 100 days, correct?
Yes. So Med-Aid pays for the first 100 days, as long as it's medically necessary. The first 20 days of that are covered 100%. And then after those 20 days, it goes to 80%. So if a person doesn't have a secondary coverage, like if they don't have Medi-Cal or sometimes TRICARE or some other additional insurance, they may um, they may find themselves being billed for a out-of-pocket cost.
And is it the same for those managed plans?
Yes.
Okay.
Hmm.
Mm, that's That's where those mystery
So,
bills come from.
Yeah.
Do health savings plans um are those helpful to have?
That's kind of depends on the individual. The original intent for the health savings plans were for people who have like a really high deductible. So when you're deciding when it's open enrollment for your benefits, and you're deciding what whether to go with the gold plan, the silver plan, or things like that. Of course, usually the more you pay, the lower your deductibles are. But for those low monthly premiums, they have a higher out-of-pocket expense, or higher deductible. Like, for example, if you have a family of four, you may need to meet a $5,000 deductible first before the insurance starts paying, towards your claims. So the health savings was just a way to get you to put pre-tax money that's not taxed in a savings account so that you can use toward those deductibles and co-pays until it's time for the insurance to start paying a higher portion.
Yeah, I know sometimes people will even use health savings plan as like a retirement plan in a way. Like they'll start stowing money away in there as like an additional stream of income on the side, um, which is an interesting trick that I've heard of in like just reading like money books,
Oh,
reading
wow.
about money and stuff. It's a
Uh-huh.
little interesting, a little weird, but I don't know.
Oh, wow. So yeah.
Okay. And which insurance is best to cover that? We said that if therapy services is
medicine,
part A. And what's an HMO in particular? Is
Um,
that how does it differ?
so the HMOs, of course, they're the health management option or organization. They are they mainly focus on preventative care, and they're usually linked to a particular organization of doctors. Like, you may have some that are Hills physicians, or you may have some that are, for out in the California area, UC Davis, or Adventist. And so those are doctors that have a contracted amount for their services. And so that's why when you're in an HMO plan, it's managed, your care is managed by the plan. And so, like, for any other services you may need that are outside of your primary care doctor that you're assigned to, you would need to get a referral or prior authorization before you can go to those doctors. And those are usually beneficial because, for the families or individuals who can't afford a higher out of pocket toward a medical plan.
Okay. And I know that usually your patients are usually kind of on the older side. Usually in skilled facilities, we see more geriatric or even
Mhm.
just 50 and older, um, which are not old people. I'm not saying anyone 50 and older is old. Um, but but for people that are younger, so like younger adults, insurance plans that are kind of best for them. I know that in general, younger people aren't seeing doctors as frequently because they don't have a lot of medical conditions usually.
Mhm.
But what is like an insurance you think would be best? Is like an HMO better because of how they focus more on primary care? Or I mean, they don't qualify for Medicare, right?
Um, in most cases, they don't, unless they're they have like end stage renal failure. That's usually when they can get the Medicare prior to being 65. Um, the best, because of course, personally, I've had both. Um, HMOs, of course, are good. It's better to have something than nothing. But I prefer personally a PPO, or just like a gold, or um, the higher plans, only because it gives you the freedom. Like, if If I need to go see a cardiologist, I don't want to wait for a referral. I don't want to have to go to these particular doctors, especially in like an area where there are not many providers or specialists. Then you may find yourself paying more out of pocket. Then with a PPO, the preferred option, they give you the freedom to go to like a higher field of providers and kind of go out of network and not accrue any higher penalties for that. So I would recommend a PPO if someone were choosing a health plan.
So, what insurances are difficult to deal with, and why would you say that? I have one in my mind. I'm not going to name Kaiser. Um,
You just
um,
cough that out.
um, but yeah, what insurances are difficult to deal with, and why?
Just from from a working in a skilled nursing environment, it's usually kind of hard with the with the managed Medicare, because they give they give a anticipated discharge date, and regardless of the therapy notes, regardless of how far they're walking, regardless of what level of care, if they're not at their baseline, they just, they're like, okay, well, most people are well by the 20th day, so you have to come up with another option for discharge. So
Here,
those are kind of hard, the managed Medicare.
Hmm.
okay, so but I guess my thing is this: if the documentation that people are providing shows that a patient still requires assistance, it's like it's being ignored. That's kind of what it feels like, because the documentation from a physician, from the nurse practitioner, from therapist, all showing that the patient is not progressing and still needs more help, but they still go home.
Yeah, I agree, because a lot of times, myself as a social worker, my main focus is to make sure the discharge is safe and that they don't end back up in the hospital again, or worse. And I know that home health is, of course, extremely beneficial, but sometimes some people are not there yet to discharge and go to home health. I think that is documentation is very crucial, especially from the nursing staff and from even the social worker. If there's like things that cognition, excuse me, cognition, or if there's barriers with depression or psychosocial things that may affect the person going home. I know that I always recommend whenever we're getting to issue a what we call a nom-knock, or the end of the Medicare coverage. I always offer the patient the right to appeal, and I actually encourage them to appeal, because that's when you go in and you can give that additional information. And sometimes I'll go in with my rehab director, and we'll call the insurance company, and we'll do a peer-to-peer, where we just kind of go into like a little more detail, because of course the documentation is good, and they make their decisions off that. But sometimes it does take um, that extra push from the provider,
Absolutely, yeah,
just saying, this
yeah.
you see that person on paper, but we see them in person, and they are
Right.
not ready. And then they can go into more detail and elaborate more. And sometimes that in itself can get a decision extended, or sometimes even if you have to go to a second appeal, I encourage, because I rather, all they can do is tell you no. And so I rather, appeal it once, and if it doesn't happen, I would appeal it again, because, at the end of the day, their safety is the most important thing.
That's right.
I have a question. You know how people are on Medicare Part A, Medicare Part B, just straight. Um, what allows a person to be able to, let's say, get care in a, lack of other words, high end care facility versus like a low end care facility if they both have the same insurance?
Um, I think it's just bed availability if it's insurance coverage. It's just what facility is accepting the referrals from the hospital. But then I think with the aftercare, like if a person is not safe to discharge home and they then need to go to a an assisted living facility.
Mhm.
Those things, the assisted living facilities are not covered by Medicare at all. And so so then that's when they have to pay out of pocket. So of course, for a better facility, you're going to pay more versus the lower end assisted living facilities are just, enough for a person to get by. I think the best thing for us to do is either, you know, to be proactive instead of reactive, is to invest in long-term care insurance. And then that way it covers, things that Medicare will not cover as far as assisted living or something like that, and caregivers.
Now, I
Yeah.
actually did look into long-term care insurance, and they want roughly $560 a month.
Ooh,
Hmm.
Mm,
Long-term care, yeah, $560 a month, and it's one of those things where you use it or you lose it.
wow.
oh,
So, yeah,
This seems
yeah. So there's another way around it. There's another plan out there that's available too, where you don't lose it and you can transfer the money over to a family member if you don't use it. But still, that fee was a little bit lower, but you're still looking anywhere between $300 to $500 a month. It's that's a car payment, but
I
I
feel
mean,
like
if you want,
insurances in general are expensive though. I
yeah.
mean,
So we have to that, and I guess that's the difference between, like I said, high end and low end care when we're older. Is if we don't put that money into it now, we'll
and
be
that's
there Medicare Part A and B at the low end facility.
is that 3 to 500 like now is we're young people, or is this when we get to a point
This
where we
is
can't really
look,
move around?
this would be somebody over the age of 45.
Okay.
But most people, they'll tell you don't buy into it at the age of 30 though.
Okay.
It's
But
not
you're
suggested
paying
to buy in when
you're
you're
still
young.
too young, and you probably
Yeah,
lose it. You're not gonna be able to use
right,
it.
right.
but
You're
I
yeah,
mean you're paying this monthly for the rest of your life while you're in long-term care?
correct. Correct, until you need it.
Wow.
Because it's the average amount that they suggest is somewhere about $200,000 is what you're going to need at end of life. So they want you to buy into the policy, and of course, your monthly goes up the older you get, the more health insurance. So it's like there's a window. So they want you to be not too young, but not too old. Very little health, problems, because then the more your health conditions are, the higher your premiums are too. So it's like there's a window that you got to get in there.
A wonderful system, don't we?
Yeah. Audience, if you have questions, please leave them in the comments, and we'll start our Q&A segment.
Mm.
I think we have one or two over here already.
Yeah.
It looks
What if
like Chris said, "What if the company that you work for does not have a PPO?"
Um, if the company doesn't have a PPO, then I mean, of course, you can always purchase like a health plan yourself. Sometimes what I've seen is if depending on your income and things like that, you may qualify for a discounted PPO plan. Sometimes the one that you pay for just on your own may save you more money than what you may pay through your employer.
Right. And Chris also said, "Why do we have a PPO or HMO? Shouldn't people have freedom to choose?" I think insurance in general is freedom to choose. I would think. I
I
mean,
think it's
no one's
about
forced into. You can say you don't want any insurance at all. So
yeah.
Yeah.
But I think having the two types is about saving money, really.
yeah,
That's really great.
And options, giving you options, like she
Right.
was saying earlier, the PPO allows you to be able to choose different physicians, whereas the HMO's closer, a little bit more like Kaiser. Well, Kaiser, they're their own beast. Never mind.
Yeah.
That's
The,
what
the Kaiser, you know what?
we
I
mentioned
looked
earlier.
at Kaiser. I was at Kaiser. Kaiser is a lot like the military. That's what Kaiser is.
I've heard that
It's a
they're
Yeah,
better
I
lot.
for
have
younger
TRICARE.
people. So
It's a lot like TRICARE military insurance. I was like, ooh, gotta get out of here.
You gotta get out of here. You're like, no, not me.
Kaiser's like, nope. If they're not attached to Kaiser, we can't even talk to them. I'm like, oh,
Yeah, and you have to like go out to where they are. Like
yeah,
people haven't. It's too much. You need
yeah,
options. You need options with your flexibility with your insurance.
right,
It's
right.
helpful.
Yeah.
yeah, I've heard that they're good for younger people, not so much older people. Kaiser, I'm talking about.
Yeah, I think so. But still, it's just like when you're limited to a spot. What happens if you travel somewhere and there's no place that I mean, Kaiser's not everywhere.
Yeah.
Right. I was
So
worried about that when I went on a trip overseas with my medical insurance. I just kind of had to just hope, like your parents there, because I had no idea what would happen. Sick. I was just like, well, hopefully I don't.
Lucius says, why are there so many variables when it comes to some of the simplest forms of care? That's a good question. It kind of sucks, but you kind of got to pick the one that works best for you at the end of the day. That's all you can do.
Yeah, they got to have a board of directors and everybody else, like those who's over there displaying. It's all about the money.
You know,
It's a
there's
business, and that's another thing people don't realize too is health is a business.
mhm.
So I had a speech therapist come to me the other day, and well, a couple months ago, and she did an interview with me, and she asked me about being a medical speech pathologist and everything. And I said, first thing you need to understand, you can love and want to care for people all you want, but first and foremost, understand this is a business first, and then it's caring for people next. It shouldn't be that way, but that is what it is. You know.
I flip it the other way. To be honest, I can't do
You have to, when we go to work, we see it the other way,
it.
right? We get there, we wake up in the morning, we're going to care for people. But at the end of the day, it's a business.
I mean, yes, it's almost like we want to see all the patients that we would like to see, but then it's
Yeah,
like you have to make sure the documentation is in there because otherwise you don't get paid, and neither does the facility because there's no
yeah,
proof that it happened, that type of thing.
yeah.
Um, but it's still, I don't know.
I have
I think for
patients I
me, I
want to
just
see.
always still like to see it from the lens of we're doing something that we love to do and that we're taking care of
Oh, yeah.
people.
I have patients I want to see and I can't see them just because of their insurance.
Um,
I can't see them. So.
yeah. All right, so we're gonna wrap it up, guys. We appreciate our followers who have tuned in with us every 2 weeks since we started this June. We definitely felt the love, as we say. So, if you want to speak with any of us about primary care, physical therapy, speech therapy, you can connect with us through our individual social media platforms. I'm at Interval Care, and Zenzele is at New Life Rehab, and
Mhm.
Olu is at Graceful Hands Rehab. Be sure to check out our past episodes on our Facebook page at the Medical Report here, and our episodes are also available in audio only version on Spotify as well. As always, we hope you stay well until next time.
All right.
All right.
Peace.
Bye.
Thanks,
Thanks
Natasha.
for joining us, Natasha.
You're welcome. Thank you.
Thank you.
Stay tight. Don't go no